Dr. Rob Paul, and he is a private practitioner in the Western Australia, and his practice, his focus is on the cataracts, cornea, and refractive surgery.
Go ahead.
He's a brilliant surgeon, and you will see that him operate very soon on this patient, who is a 54-year-old lady, and like the first one I saw, asking for spectacle freedom. And here we have an astigmatism which is being built with Access of IQ restored toric. And you can see on the right-hand side the axis and the diopter. But once again, the surgical induced astigmatism calculated here is 0 because with 2.2 it's not very far off from 0.1. So
Dr. Paul, in 1 minute,
like Paul McCartney, he also put 0. But I must say, I do myself sometimes 0.1 and sometimes 0.2 if I'm not having the aspheric part of toric.
Good morning, everyone. Look, it's a pleasure to be here, and look, let's get on with the case without further delay. Now, what I do is I do a 2.4 millimetre two-step incision. That's my standard incision under topical anaesthesia. So what I do next is I put a bit of 2% lignocaine into the eye. Just coming up here, there we go. And I've already pre-marked the patient, and I'm a little bit fortunate in the sense that her axis is very close to 90, the axis of insertion. Now I'm just going to put in my preferred viscoelastic, which is a bit of viscoat into the eye, just coating a little bit of the peripheral cornea as well as the endothelium. I'm just going to do a little bit of a modified soft shell technique, put a bit of Provisc in the middle. It's important not to sort of overinflate the eye, because I do find that when you do your capsular axis, it can become a bit sticky. Now, I'm just going to do my 1.2 millimetre incisions now, using my dual bevel blade, which I find these blades really good, and it's important not to go the whole way through, because if you do, you tend to end up with a leaky wound afterwards. Just a bit of BSS on the eye, thanks. Thank you. And it's right now I'm thinking, gee, wouldn't it be wonderful to have one of those LensX machines, Michael, right here at the Eye Institute. There you go. Look, I do my capsular axis with a needle. I just find it gives me quite good control in the AC. There we go, done. I like to milk, now don't get disgusted anyone out there, I do like to milk a little bit of the viscoelastic out of the eye, because what I don't want to see is a capsular distension syndrome, particularly if when I hydrodissect. Couple of small pulses, push out this way. Go in again. And I'm doing this with 2% lignocaine, just because it gives me a little depot of local anaesthetic. Try and do a little bit of a hydrodilation as well. Good. Okay. Feel free to fire away any questions. It does a little bit. Look, that's why I don't try and go too aggressively, because what can happen is I'd hate to see any sort of iris prolapse. So here I'm using my 45-degree tip. Don't like to go too deep, but just try to get a bit of a separation of the quadrants. Yep. Yes. Look, sometimes when I've got a very good hydro delineation, I can just separate it into halves. I don't like flipping it into the AC. I'll tell you why. It's because I'm very conscious about the endothelium. Even with the great viscope present. And as always, with a bit of viscoat, you do get a bit of some of the nuclear material just getting up to the top there. Good. IA, thanks. Yes, please. Look, I use a bimanual IA, and I know that's not used a lot over here in the eastern states, but I do like it because it gives me good control of the eye and also lets me access the subincisional cortex quite nicely. And any bits of fragments that hang around too. Sometimes these can just fly out the port, but I'm just cleaning up that little bit of posterior capsule change there. Good. Can I have the Provisc, thanks? Now this lady was an interesting lady because she actually had very steep corneas but a small eye, about 21. And what I just want to check is it was 88, that was the incision. Now, where I did my marking was about 90 and 180, so that's pretty spot on. So 88 is just at the edge of my pink marking there, purple marking. That's where I'm going to be aiming my lens to go. Look, I don't like to put too many instruments into the eye, but I'll try and rotate it around as good as I can with the actual cartridge introducer. Can I have the mushroom, thanks? Thank you. And look, there's a bit of an epithelial change there from the anaesthetic. Now, here we go, lining it up. A little bit short of where I want to go, just in case I need to touch up any further movements later. Now, IA. Great. Look, what I do is I sometimes shift the lens to try and get a little bit under it and give it a bit of just a lift up and get that viscoelastic out. I really do not like putting bimanual vacuum under the lens because it'll mark the lens, and also I always worry about grabbing the capsule. I like to push down firmly on the lens as well, centre it quite nicely with that reflex. Beautiful. Thank you. Just BSS, thanks. I'm just going to hydrate my wounds now. Look, what I also do, when I'm hydrating the periphery of the cornea, of the main wound, you can get a bit of a fish mouth. So I do like to just give the roof a bit of a squeeze of BSS. And finally, I'd like to push down on the lens, still making it sure it's up against the posterior capsule and that the axis is still perfect. And I slightly decenter the restore lens, because as you know, it's a multifocal lens and we need to get it spot on. Last thing I do is a bit of Kefazolin. Have you got the betadine for us? Oh, that's okay, I'll do that at the end. And that's pretty much it. Little sting now, my dear. There we go. Okay. Thank you.